Hello, everyone. My name is Bansi. Just for a quick introduction, I'm one of the ST2 trainees at Leicester at the moment, and I've been asked to go through basically the fundamentals of how to go through a chest X-ray, which is what we'll be covering first, then how to go through abdominal X-rays, um, and the format I've sort of selected is mainly case-based. So I haven't done many of these Zoom sessions, but I hopefully want it to be as interactive as possible. Otherwise, it'll just be me doing a lot of talking, and plus with exams coming up and so on, just practice is probably the best way to do it, even if you don't know what the answer is. Some of them are obvious, some of them might be a bit more subtle. They're all meant to be common things, so none of the rare niche congenital syndromes or anything like that. So yeah, without further ado, I'm just going to start. And then we can get started. If at any point you'd want me to stop, just mention it in the comments, and either myself or Aaron or someone else would pick it up and sort of just flag it up. Let's go with this particular topic and so on. I just want to mention that there were plenty of useful contributions from a junior clinical fellow at University Hospitals of Coventry, where she shared some cases and so forth. So I just mentioned her here to give her the credit that she's due. But yeah, without further ado, let's start the presentation on this session. So this is what we'll be doing today, and the key emphasis being on common here. So it's not extensive. In fact, there are a lot of common things that I didn't get to cover with the interest of time. If people want to cover a certain topic, and we do have time in the end, I'm more than happy to do that. Fine, let's get started. Now, it's always good to start with the basics. So I've sort of just created this labeled diagram of a chest X-ray just to orient people to the basic anatomy. I'm sure this is quite familiar to all of you. Just certain key points I just want to go through. I'm sure a lot of you know this already. So the carina is quite important. We'll be coming across that in the future. The obvious ones mentioned here. Yep, so the pulmonary vasculature. I mean, most of this we'll go through in more detail, but just, this is the general overview of what consists of a chest X-ray, because there's a lot of anatomy that we can't see on a chest X-ray, and therefore the emphasis is on what we can actually visualize. Fine, so just going through the same step by step. We've got the trachea going centrally. The point at which it bifurcates is the carina. This is quite important, especially when it comes to NG tubes or ET tube placement. You've got, just going along beside it, you've got another prominent mediastinal landmark, which is aortic knuckle, which is where the arch of the aorta transitions to the descending thoracic aorta. So yeah, that's that. You've got the two lung hilar regions. Now the hilum is sort of an area of the pleural root, basically, where you have your pulmonary vessels, your bronchial vessels, and your bronchi themselves pass through. So it's a concentration of vasculature and airways that form prominent markers on a chest X-ray. One important point just to note is the left hilum should never be lower than the right hilum. And this is to do with the anatomical arrangement of the vessels themselves, which you can look up in more detail in cross-sectional imaging and so on if you want. But the main point is the left hilum should never be lower than the right hilum. If the right hilum is above the level of the left hilum, you should be concerned about something sort of pulling the right hilum up or depressing the left hilum to be causing that. So that's that. Now, with regards to the hilar region, we mentioned the pulmonary vasculature. This is probably the most prominent bit of that. So you've got the pulmonary arteries coming off from the right ventricle, and that's what gives this sort of spread on both sides, originating from the hilum. And that's what we can partially visualize, some of the big segmented branches of the pulmonary arteries on both sides. Fine. Now, something that I was initially confused with when in med school, and that took me a while to get my head around, was the idea that yes, you've got a complicated 3D structure, that's your thorax and all its contents, but what we've got on here is a 2D representation of that. So whenever we're talking about the lung field specifically, we refer to zones of the lung when it comes to the chest X-ray. We very rarely do we mention directly, oh, there is this pathology in this lobe. And the only circumstance we do that is if we've got some other indication of localizing it. But otherwise, whenever you're talking about pathology, if, for example, there's a solitary lesion in the right apex, I would refer to it as a solitary well-circumcised lesion in the right upper zone. I would not say it's the right lobe, for example. So yeah, it's just, that's mainly a question of terminology. It's slightly different between chest X-rays and more cross-sectional imaging, but you guys don't need to worry about that. Just stick to zones. And the zones are fairly straightforward. It's roughly a third of the lung field that you can see. It's just called the zone going upper, middle, and lower. And yeah, I don't think there's much more to be said about that. No, forgive me if this is basics. We'll just quickly go through this before we get on to the meat of the talk, which is basically cases. Again, some basic anatomy. You've got the right hemidiaphragm, the left hemidiaphragm. The right hemidiaphragm is superior generally compared to the left hemidiaphragm. That's because of the fact that you've got this big organ underneath, which is of course the liver, that's pushing it superiorly. You've got the two sets of angles where the diaphragm interacts with the mediastinum and the peripheries. So one of which is the cardiophrenic angles. And this is important because if you have this blurred, it could suggest there's pathology there, and you can localize that further, which is something we'll go through in more detail later. And similarly, you've got your costophrenic angles. Now, costo, rib, phrenic, diaphragm, and cardio, again, heart and phrenic mean diaphragm. So the names are pretty self-explanatory. You've also got the spleen tucked around here. We don't really interpret much on a chest X-ray with regards to spleen. The stomach bubble is important in certain aspects, particularly hernias, NG2 placement, etc., etc. So that is something that to be aware of and to keep an eye out for. Fine. Now, just as I mentioned earlier, you've got the costophrenic angle being formed here. And that forms a recess. Now, this recess is important because in a normal PA film, if you have any fluid collecting in the pleural space, now bear in mind between the parietal and visceral pleura, you've got a potential space there. And if there is something that causes fluid to accumulate in that, most common cause being things like infection, heart failure, malignancy, that fluid tends to accumulate at the bottom of the pleural spaces. So this is a very sensitive indicator of if there is a pleural effusion, and that's why that's quite important. So we refer to it as blunting of the costophrenic angle, because you're meant to see this nice sharp outline going all the way down, and if that gets obliterated, you're concerned with fluid again. Now, this is also an important concept. It's quite simple in the sense that you're just looking at the cardiac diameter roughly compared to the entire thoracic diameter. Sorry, I shouldn't say diameter, I should say width. And it should be less than 50% of it. So for example, here, you've got a perfectly normal cardiothoracic ratio. And this is important because it's an important sign in heart failure, because in advanced heart disease, you end up with dilatation of the muscle because it's trying to compensate for all sorts of causes of weakness, maybe previous infarct, etc. It could even be congenital, and that results in cardiomegaly. That's important because if you're likely to have heart failure, that could have lots of prognostic indications when it comes to surgery, etc., etc. It also could explain some of the signs you see, such as pulmonary edema and so on. We'll go through that in a bit more detail later, but the main thing to take away is that this golden figure of less than 50%. Doesn't need to be very precise. Usually, if it's 51% versus 49%, doesn't really make that big a difference. That's still close enough to normal. In cardiomegaly, it's usually quite obvious, and often you'll find other signs to suggest that this patient's heart's not doing that well. One other thing I just wanted to add here is that, yes, you've got the 4 chambers of the heart, you've got the 2 upper atria, and then you've got the ventricles. But when you look at it on a chest film, the orientation of the anatomy is actually not that straightforward. So you've got the right atrium, which forms the heart border on the right here. Now, on the left, while it's roughly symmetrical on the chest, it's not the left atrium. The left atrium actually is, the way the heart's arranged, is actually the posteriormost chamber, and you don't actually visualize it that well on a chest X-ray usually. What you would see is actually the border of the left ventricle. The right ventricle and the left atrium are not normally visualized that clearly on a standard PA chest X-ray. There are other certain indications you look for, and they can be indirectly seen in radiographs, especially on lateral views or in things like barium swallows and so on. But you guys don't need to worry about that for your exams. Just remember, these are the rough borders. This is what actually constitutes the border. The right atrium on the right, and left ventricle on the left, and the cardiothoracic angle. Cardiothoracic ratio being less than 50%. Now, just want to talk to a bit about the quality of the film itself. Now, whenever we look at radiographs, there are certain indicators we need to look at to see if the film is adequate, because if it's not, we can get false appearances of pathology. Now, I'm sure you guys have read all about this earlier, but I'm just going to go through it again, just from a point of view of the bare basics. So the way we assess rotation is we look at 2 structures on the anterior aspect of the chest, which would be the medial aspects of the clavicle, and we look at a structure on the posterior aspect of the chest, which in this case are the spinous processes, which you can see quite clearly here. And the logic being, if you've got something that's at the front and you've got something at the back, and they're aligned roughly perfectly, then the film is not rotated. If you get a change in this, so if you see that the distance between them is not roughly equidistant, it would suggest you've got rotation either to the right or to the left, which is not that uncommon, especially in sick patients, especially in AP films, which are like portable AP films. You will see that, and that's just something you have to deal with because it's not possible to position the patient normally. But while presenting a film, it is something to comment upon to see if there's any rotation or the film doesn't appear to show any significant sign for rotation. And that's roughly how you do that. Look at the medial heads of the clavicle, draw a line between them, draw a line in between the spinous processes, and they should be in alignment, and they should be roughly an equal amount of gap on the right compared to the left. So yeah, that's that. Now, another feature to look at is penetration. Modern days, we can do a lot of windowing and change the appearance of an X-ray, which you might have seen being done. But it is still important to note if the film is adequately penetrated or not. And what we mean by penetration is how much, I guess the simplest explanation is to what depth can we discern a structure clearly. So here, for example, we should be able to clearly make out and distinctly identify a separate vertebra through the cardiac shadow. that's a rough rule of thumb to say that it's adequately penetrated, because you're going through soft tissue and you're still being able to distinguish them. If a film is not adequate, sorry, if film is not adequately penetrated, there will be certain problems. For example, you will not be able to delineate clearly the margin between the diaphragm and the spine here, which, for example, if there's a hiatus hernia here, which could very easily happen, if it's not adequately penetrated, you wouldn't be able to see it because it'd just be a whiteout and you wouldn't be able to delineate the different structures there. Sometimes it can also lead to people falsely assuming that a silhouette has been, or rather, you can't really comment on the silhouettes when if film wouldn't be adequately penetrated. That's why it's important. So it's also something to comment upon. Now, inspiratory effort is something that we learn a lot about often in real life with patients. You'll often find them struggling, especially if they're breathless. It's very hard to get them to try to take a good deep breath, but that's what we ask them to do. Roughly, the way this is measured is for minimal amount of inspiratory effort, you should have the midline, mid-clavicular line, and the diaphragm shouldn't intersect any superior to the anterior aspect of the fifth rib. It doesn't matter if it's the right or the left. I just pointed here on the right because it's easy for me. And it shouldn't be more than 7 ribs. Because if it is, you're thinking, is this hyperinflated, which could be someone just being very keen and trying to take a very deep breath, but more often you're thinking of conditions such as COPD in the context if you see that. And often in those cases, you also see a flattening of the diaphragm. You might get some blunting of the costochromic angle as well. So it's not usually seen in isolation. It's a cluster of things, but this is roughly the angle to look for. As you see more chest X-rays, you don't necessarily need to always have to count going, counting down the ribs. I'm doing so, but if you're ever unsure, that's always the best way to do it. Count the ribs going down, mid-clavicular line, draw an imaginary line, and should be roughly between the fifth and no more than the seventh. I'm sorry, the anterior aspect of the rib there. Fine, that's all to talk about that. Now, one thing I do want to touch upon specifically is AP versus PA projection, and how that's important in the context of cardiomegaly. So basically, because of the way the source and the film is arranged in an AP film, which makes it more convenient to take a picture in someone who can't mobilize, so a patient who is either too unwell or just not cooperate enough to shift them in traditional positions, standing and having their arms out of the way and so on and so forth. What you end up is a slight magnification of the apparent heart size because it's closer to the source and therefore its shadow appears slightly bigger. Now what that means is that if you see a slightly enlarged heart on an AP film, you cannot diagnose, or it is fair to say that it is difficult to comment on the heart size on an AP film. If the heart size is plumb normal, so if it's say 45% of the overall cardiothoracic ratio on an AP film, because of the way it works that the heart size tends to be magnified, that's okay, because that would usually indicate that the heart isn't enlarged. So it sort of works as a negative marker in that if the heart size is not enlarged in an AP film, that's fine. But if it is enlarged in an AP film, don't jump in and call it cardiomegaly unless you've got other signs suggesting of the patient being in chronic congestive heart failure, for example. But that's just something to note. Generally speaking, through med school, I've always said, oh, this is an AP film. Therefore, it's difficult to comment on the heart size, and no one ever penalized me for that. So if you're ever stuck in that works as well. Now, I'm just going to go through what I use as my basic approach to presenting chest X-rays. This doesn't mean that you have to follow it. Everyone does things slightly differently. So whatever helps you remember, as long as you look through all the important sections that can be visualized on a chest X-ray, everything is perfectly fine in that sense. So the way I divide it is quite simple, because it's just easy for me to remember, even in the middle of a stressful exam, for example, is just A, B, C, D. So A is your airways, B is your breathing, which I use as a memory tool to think of all the lung fields and to look at the different zones and comment upon them. C is your cardiac shadow, see if there's cardiomegaly, to see if there's dextrocardia, which is just the card being on the right-hand side as opposed to the left-hand side. Also refer to the heart borders, and to see if there's any disruption of the, if there's any pathology behind the cardiac shadow, which is something we'll talk about. D, I just refer to as the bones, because I just always seem to forget about the bones, so I just label those, don't forget about the bones. Because you can have fractures. It would be a bit mean for them to throw a chest X-ray to, with the only abnormality being a fractured humerus, or having some minimally displaced fracture of the scapula. That would be mean. But the other common fracture that people do miss is rib fractures. So it's always worthwhile that even though you look through the lung fields, look through the ribs, make sure that they're symmetrical, and make sure that they don't show any obvious breaks or anything like that, or any implants, etc., etc. Fine. Now, E, sorry, I mean in terms of bone nailing for humeral nails or orthopedic inserts or anything like that. Now, E, I use as a catch-all term for everything else, which I know doesn't help, but it basically refers to all the areas that I haven't missed, which the way I think of it is, one, the center of the chest X-ray itself. So you've got your two hilar and you've got your different mediastinal contours and your knuckle, for example, and so on and so forth. And everything else that we can add on. Another way to think of it is E for external objects, which is important when it comes to shapes and lines, but doesn't really help you with mediastinal contours. But we'll go through cases, and a lot of this is just repeatedly doing it again and again and again, and until you become comfortable doing this. Now, I'm sure you've heard this term being thrown about, the silhouette sign. This is a bit of a misnomer, really, because what they're referring to is you've got your normal cardiac silhouette, a normal silhouette on your chest X-ray, and you've got something that's disrupted silhouette. So what it actually refers to is the loss of your normal silhouette rather than forming a new silhouette itself. I've just mentioned some common points here. This is by no means extensive, but it's just a basic set of things to remember. So if you've got anything obscuring the hemidiaphragm on either side, that tends to be lower lobe disease. If you've got something, again, bear in mind that you've got the retrocardiac part of the lung as well, which is an area that people often miss. Again, if you've got something there that appears fuzzy, indistinct, it doesn't matter if you don't know exactly what it is and you can't exactly trace its outline. Basically, if something looks abnormal behind the cardiac shadow as well, odds are there is some pathology going along there. It could be a hiatus hernia, it could be cancer, it could be pneumonia going along there as well. If you've got something disrupting the silhouette of the aortic knuckle, for example, you're more likely looking at upper lobe, left upper lobe pathology. There, if you've got a disruption of the border of the right atrium, that's right middle, that's a strong indication that there's some pathology going along in the right middle lobe there. These are one of the few indications where you can actually comfortably say, okay, this pathology is most likely localized to this lobe, because the different silhouettes. But otherwise, generally stick to zones. And again, if you're not sure, stick to zone. Yep, so that's basically that. There's not much to say. Right. Now, another thing to talk about, and what I'll be going through is basically some cases and some specific signs. Now, these were terms that were thrown around a lot at me during med school, I remember distinctly, and I didn't always know what they were, so I just wanted to go through the basics again. So this is an example where we've got a distinct area of high density located in the left middle and left upper zone. In that, you can see what's known as an air bronchogram. An air bronchogram is nothing but the fact that you've got your small airways which have air in them. That's why they appear dark, because on a chest X-ray, things that appear bright have higher density, things that appear darker have a lower density, and air is minimal density compared to all the other soft tissue bones, so it appears dark. And you've got that highlighted on both sides with basically gunk. In this case, you're thinking of a pneumonia. What's there? Probably combination of pus, white cells flooding to the area, bacteria, necrotic tissue, edema, inflammatory changes, whole host of things. But what that results in, gunk surrounding the airways, which is why you see this very nice clear pattern. You could almost with a pencil go and draw out the different airways extending far beyond the hilar. So that's what's known as an air bronchogram, and that's a pathognomonic sign for a lobar pneumonia, or at least pneumonia consolidation rather on that particular zone. Right, so I just thought sort of summarize a lot of what I mentioned. This is how I would, for example, present a chest X-ray. So always, now with a lot of my cases, I have to apologize, is that I haven't added things like the name of the patient, or even a fake name, and the date which is taken on. But you might be given that in an exam, and even if you're not, it is worthwhile just saying, you know, and developing it as a habit to just say, this is a PA film of Mr. So-and-so or Mrs. So-and-so, taken on whatever date it is. Now, then comment upon if the film is technically adequate. So for that, go back to the basic principle we were talking about. Is there rotation? Doesn't appear to be rotated. You've got the spine there, and you've got roughly the two heads there, and it seems to be roughly the midline. So that's fine. So draw an imaginary line there, and that matches. That's fine. It's adequately penetrated. I can see the pedicles of the vertebra through the heart itself in the midline, which is fine, and I can distinctly make out the different vertebrae. So it's adequately penetrated. And there is good inspiratory effort on both sides. There's no blunting of the costophrenic angles, and there's no flattening of the diaphragm to suggest there's hyperinflation either. So it's a technically adequate scan. Then comment upon go ABCD sort of pattern. Trachea is central, which is your airway generally. Then you've got lung fields are clear. It's just having a look. Bear in mind, I know it's one sentence, but make sure you have a look. Compare each side to the other. So upper zone, middle zone, lower zone, that appears to be fine. The heart is not enlarged. You don't need to measure the ruler. You know roughly that it's within 50% of the overall thoracic volume, which is fine. The costo and diaphragmatic angles are clear. They're very crisp and nice, as you can see on both sides here. So there's no fluid or any masses that you're worried about. The mediastinal contours are normal by mediastinal contours. One of the things mentioned is the aortic knuckle going along there and the aorta along there. You're also looking at the right paratracheal stripe, so this line here. And usually if you have any disruption or masses there, you'll get to use trachea. But yeah, so the mediastinal contours are normal. There's no, we might usually when we refer to that, we talk about the disruption of the pattern or widening of the mediastinum. There's no bony abnormalities, so I'm looking through all the different ribs. There's no fractures there. Clavicles look normal. What is visualized of the scapula doesn't show any break. And no significant soft tissue abnormalities. One thing I should have mentioned earlier when it was looked at everything else is surgical emphysema, because that's something I actually remember being questioned in exams and I completely forgot. We will go through that separately, so don't worry about that. And finally, summarize your findings. So we've gone through it, technically adequate. There's no abnormality band, so this is a normal chest X-ray. So that's just as a basic introduction to how to approach a chest X-ray. What are the things to look out for? Does anyone have any questions at this point that they want me to go through, or would people be happy to go through the cases? You can either speak or whatever people would prefer. Okay, I will take that as we are happy to continue. Let's crack on then. So that's that. Now, what I wanted to do is sort of try to make it as much of a Q&A sort of format as possible. And the single most important thing with these kind of things is to get into practice. So I don't know if this would be possible, but ideally, if you could have a volunteer that would be happy to practice either their own technique or the method that we just went through on each of the cases that we're bringing forward, because otherwise it'll just be me talking at you, which I'm happy to do, but ultimately practice is what makes, will make these points stick in their head. So is anyone feeling particularly adventurous and happy to try this case? Going once. No one? People happy to listen to me speak for the remainder of the session? Fine, let's do that. So this, I wanted to use this as an example of how to approach chest an NG tube, because this is something that's quite important. It's basically a never event when an NG tube would have gone down the wrong place, and I just wanted to use this to highlight what a normal would look like. So certain anatomical landmarks here. So whenever we're looking at NG tube placement, you've got the tube itself going all the way down, which is fine. The things to look out for: does it go along the trachea, which is what he does? Does it go past the carina, which it must always do, because the most common mistake is it going to the carina and then finding out that it's actually gone down, usually the right bronchus, and you've ended up feeding them directly into the lung, which bad things happen because you then end up with people having severe aspiration pneumonia and people have died as well. So make sure that you comment on, so it's gone down the midline, below the level of the carina, cross the gastroesophageal junction, which is roughly around there, or you could even just simply say, because we can't visualize the junction itself, has gone down below the level of the diaphragm, then has turned to the left of the diaphragm, which is what we see here. Now, this is basically the main things to look for. As long as you follow these steps, has it gone down the midline? Has it crossed the carina? Has it crossed the level of the diaphragm? And is it turned to the left? You look absolutely fine, because it's the tube that's really gone to any other bit, as long as the person's got normal anatomy. And even if you have some rare syndrome like Cartesian syndrome or cytosine where you have the gastric bubble on the other side, it's just as long as it lies in where the gastric bubble is, you're safe. Now, that's just to go through the basics of an NG tube. Now, this is another case that I just wanted to go through here. So here we've got a film where the most prominent abnormality. Does anyone actually want to at least type out what they think the most prominent abnormality is?
We might have some potential people who are keen. Andrew, would you like to have a go?
Yes, please.
Yeah, I will do. Yeah, I'll just have to go inside because I'm outside at the moment. Can you hear me?
Yes.
Yeah. So, okay. So this is a chest radiograph of an unknown person. Rest of the details are unknown as well. Rotation, inspiration, penetration looks adequate. The most obvious abnormality is pneumoperitoneum. You see that under the right diaphragm. So just carrying on, the trachea, I mean, it does look to be slightly going off to the right, but I'd say that was normal. But I could be wrong. The lung markings, I don't see any like signs of pneumothorax or anything like that. The hilum look normal. The heart borders, I mean, there's something, I don't know if there's something going on with the heart borders. It just looks like where the hilum is, it just doesn't look quite as crisp as it should do. But there's no, assuming this is a PA view, which I'm assuming it is because it doesn't say otherwise, then the heart's about the right size. It's not more than 50% of the ratio. And then just looking at the bones, I don't notice any abnormalities in the bones. And there's no other extra features. So in summary, I'd say this is an abnormal, well, there's some kind of pathology going on due to some GI pathology like perforation due to the air under the diaphragm.
Which is a very good presentation. Absolutely like that. You've clearly done this sort of practice quite a lot previously. I just wanted to ask, following on to that, what would your next step be if you see a chest X-ray like this? I may have lost Andrew, but that's fine. Basically, what I was getting at is if you do ever see pneumoperitoneum, exactly as Andrew mentioned, that most likely you're suspecting GI perforation. Unless this patient has known GI surgery in the very recent past, you would get a surgical opinion, yes, and they will be heading towards a laparoscopy or some other surgical intervention to find out why they're doing that. You could even look for further imaging, further identify that with CT. But yeah, that's just something for extra brownie points to mention. One fact I do want to mention is that you've also got a bit of bowel loop here, which is not in itself not that abnormal. I suspect there's actually gas on both sides here, because normally with the gastric bubble, you wouldn't see this smooth pattern going all along the hemidiaphragm. So yeah, you correctly identified, yes, it's clear pneumoperitoneum under the right hemidiaphragm. But there's probably also on the other side as well. Doesn't really change the diagnosis of the patient. Here, I wonder actually, I mean, I didn't focus on that much when I was selecting this X-ray, but I wonder if this film is slightly rotated here, just looking at where the spinal process is in relation to the right versus the left. In this particular case, that doesn't really change the assessment of the chest X-ray particularly, but that's just something to mention. Fine. Does someone want to have a look at this? Just bear with me 1 second, guys. I'm trying to see if I can get the chat up at the same time as.
Sorry, Bamsi, I'll keep an eye on the chat box for you.
Okay, if you guys want, you can just type in the abnormality that you think on there. I mean, if people want to go for the whole hog, absolutely great. If not, just throw in your suggestions in the box. Give that 15-20 seconds, and then we'll go to the answer.
Alex, did you want to give it a go?
Yeah, sure, I'm happy to. I'm actually part of the committee, but I'll do it anyway if no one else wants to. So this is a AP X-ray of an unknown patient. Starting with adequacy, does appear to be slightly rotated looking at the clavicles. Penetration is good, and you can see all of the bones and the starts of the shoulder joint. Moving on to A, airway, the trachea doesn't look deviated and there's no obstruction. Breathing, lung fields appear clear to me, and you can see both costophrenic angles and the cardiophrenic angle. Circulation, heart is within normal size. And then D, bones, I don't see any perforations. All I would say I see is potentially slight, to be honest with you, I'm not sure. I would say it's a normal X-ray. Maybe it's slightly barrel chested.
Interesting thought. I haven't really thought of that. Actually, what I wanted to highlight actually is some of these changes can be subtle. So actually go to the next slide. So this is, if you go back to your normal contour, the border actually isn't as crisp as you'd expect, because normally the right atrium is meant to be a straight line going down. So it would go along that way. You shouldn't be seeing it bulge like this. Yes, you have your normal vasculature going through, but that shouldn't obscure the crispiness of the right heart border. I understand what you mean in that, yes, this is relatively well delineated, but you'd normally expect, and if you draw a line going along there, you roughly expect the right whole border to go along that way. So if I go back to, say, the previous, then as you can see, that is roughly here and along there. So this would be some kind of pathology going off actually in the right middle lobe. And this would basically be loss of cardiac silhouette here. In this case, I suspect that it's a collapse of the right middle lobe, rather than, which is why you're getting this dense, clear mass, as opposed to consolidation, which is where you're getting bronchograms, and you might get something that's a bit more fuzzy, rather than this clear sort of dense mass as we see here. So that's something to be careful of, because it can easily catch anyone out, really. Fine. So that's that. So going on to the next film. I'm just going to give people about 20-30 seconds to look at it, and after then I'll just go through to the answer, and we can discuss that. And yeah, in the meantime, if anyone wants to throw in the answers in the chat, feel free to do so. Seems to be quite popular. A lot of people are joining. So that's that. We'll be just looking at what people think. Now here, it's again a similar thing. You've clearly got some easiness along here. If you look along the border along there, that should be relatively clear. Sorry, this is the next case. In this, as if you look at the previous case, you can see the nice cardiac silhouette along there, and you can see the pulmonary vasculature, and you can see a clear delineation between them, which is nice and normal. In this particular case, you've got nice and crisp, you've got your normal pattern going along there, along there, along there. And if I draw your attention to the highlighted portion there, that normal cleaner pattern has sort of become much more fuzzy, which would suggest that there's something going on there, which would, based on the location, would probably be in the lingular aspect of the left lobe. Doesn't matter if you can't identify that. What I'm just trying to get you guys to be careful about is focus on different borders. Just get used to what normal is, and if you see deviation from that, don't be afraid or have a high suspicion of saying, okay, there's something actually going on like that. Fine. So what do people think of this? Once again, 30 seconds, and then we will be going through the we'll be going through the answer after that. Fine. So in this particular case, this would be a classic case of a lobar pneumonia. You've got widespread patchy opacification extending in the left, middle, and lower zones. Bear in mind, I say zones. The hemidiaphragm is actually quite crisp, and you can see that very clearly along there, suggesting that this isn't lower lobe pathology, but upper lobe. If you're not sure in the exam, don't stress about it. Just say that it's more likely to be suggestive of lobar pneumonia. Now, the point I want to focus on to here is, I don't know if you can see these, but these would be very similar to what you can see here. You can clearly see areas of opacification with areas of relative hyperdensity in the middle. And what that will translate to, as we were talking about earlier, gunk in the surrounding space with airways going through them. So this is pathognomonic of the lobar. Right. So the next case, have your answers thought out in your head or in the text if people prefer, and we will go through that. Yep. Well, that's perfectly right. Consultation, left middle zone. Yeah. So I would probably say that it extends to the lower zone as well. But yeah, most commonly in the left mid to upper zone. Yeah. Yeah. So. Yes, indeed, that is correct. So for this, I would say, again, the usual, this is a necessary film of Mr. X, dated yesterday. Technically, it's an adequate film. There doesn't appear to be rotation. There appears to be adequate inspiratory effort. It seems to be slightly underpenetrated. I can't make out the, while I can make out the borders of the with the spine, the background, through spinal lines. I can't make out the individual vertebra that well, so I would say it's probably slightly underpenetrated. But airway central. Now, when you come to the lung field, the thing that stands out quite significantly, you've got the hilar, which are completely out of proportion to what we normally see. So this is bilateral hilar lymphadenopathy, exactly as Ali mentioned. Bones, they don't seem to have any fractures or any of the abnormalities, but both diaphragms with costophrenic angles and costal cardiophrenic angles appear clear. Yeah, so fine. The most notable abnormality here is a bilateral hilar lymphadenopathy. I don't know if in your exams you get asked to mention differentials or not, and it would vary based on what they tell you. But this would, some of the differences you can mention is sarcoidosis, which typically bilateral lymphadenopathy, it's right on top of your list. You can also have other causes, TB based on where the patient's history is from, which can present as unilateral or bilateral malignancy can also be specifically lymphoma can present as bilateral, unilateral. I'm not sure if I haven't gone through any significant detail, but there are different differential lists looking at unilateral hilar lymphadenopathy versus bilateral hilar lymphadenopathy. But what I wanted to just get you across is usually when it's present, it's usually not subtle. It's usually quite prominent, at least as far as exams go. They tend to go for the more meaty examples. So just commit that to memory. That's sort of roughly that kind of appearance where you can clearly see a massive increase in size. Fine. Okay, who wants, all of you, just have a go at this. Tell me what you think. I hope it's projecting clear enough to pick up the pathology, and we will discuss it in a few seconds. Thank you, Sanjeev, for clarifying that. I am notoriously bad at multitasking, so I appreciate his input in answering some of the questions in the chat.
No worries, man.
Okay, let's give that a few more seconds. And then, I mean, most of these cases, yes, I would probably say that, yeah. Flattened diaphragm. You can still make out a good costophrenic angle. Actually, if anything, there's maybe slight blunting on the left, but on the right, you've got a good costophrenic angle there. There's something else that I just want to focus on. So one of the things to look out for, yes, there is a fracture. Well done, Azar. Yes, there is a rib fracture. Which side? Yes, indeed. So you've got a left rib fracture there. Now we've almost got there. What else can you notice surrounding? Exactly. Yeah, so I agree. It's a pneumothorax along there. So just to highlight that a bit more, it's a simple pneumothorax. No, I thought I highlighted, sorry. So yeah, as you can probably see, the lung markings going all the way along there to the very ends of the pleural fields along there. And you can see, always compare. Comparison is the best sort of tool that you've got. So you've got clear cortical margin going all along there. And when you follow the cortical margin along here, you can clearly see a step going along there. So what this person probably has is a simple traumatic pneumothorax. And if I had to draw the margin, it would be going from roughly along there. And if you can, I hope it's projecting well enough for you guys to make out. I don't know if you're seeing it on a phone or on a big screen or something like that. But you've got lung markings going all the way to the margin of this rib here, the superior aspect there. And then it suddenly drops. This is all pitch black along there, and that's your simple pneumothorax there. It's a simple pneumothorax because there is no tension. And by tension, what we mean is there's no mediastinal indications of tension, i.e. no tracheal deviation, no mediastinal shift. If you saw a similar sort of picture, but there was shift, you wouldn't be wrong to call that a tension pneumothorax or a developing tension pneumothorax like that. Fine, which is something I just repeated there. Right. So what is going on with this poor chap here? For one, some extra bits of information they often give is useful. So you know that it's a recession. You know there's something bad going on with the patient. Yeah. So yeah, take 30 to 40 seconds and then yeah. Yep, that's perfectly right. So it's much more obvious here. There's complete collapse of the right side, exactly as mentioned. You can see sort of this density. This is probably the lung that sort of collapsed and just folded on itself, because if you imagine a balloon that's popped, it just sort of goes along the same way. And there is mediastinal shift, exactly, and that's what makes it a tension. And you can clearly appreciate that here. You've got the spinous process here being roughly the midline, and you've got your trachea being pushed all the way along there. The carina is pushed all the way along there. The heart itself seems to be going on that side as well. High on the fracture on the right side. So bear with me. I'm not sure I can.
Are you talking about that bit, Ellie?
What you can highlight.
The bit
Yeah,
Nancy
that's me.
circled?
Sorry, I've just circled it because I thought that was a fracture.
Oh, brilliant. Yes. Yeah, no. So that's normal rib.
That's just the costochondral joint.
Thank you.
You mentioned, yeah, I'm sorry. Sorry, my screen that is going back for some reason. There we go. I just highlighted the different points just with the markers, the immediate signs left there. Yep, that is fine. I think everyone's got that. It is, these films are often called the film that shouldn't have been taken because tension is something that you should immediately treat. That might be something they may ask you in the exam as well. How do you treat a tension pneumothorax? Chest drain if there's time to arrange that. If not, it's second intercostal stem, the clavicular line, you go with the cannula and just suction the air up using a fluid flow syringe to make sure that you're getting air bubbling out. I don't know if you guys are expected to know that, but if not, that's something you can just look up because it is a life-saving procedure. And I've done it once before in my life, and it is also one of the scariest things you can ever do, going up to someone and just stabbing them in the chest based on your instinct. But yes, anyway, so that's what that looks like. It's a favorite in exams. And that's that. It's very good that you asked that about trauma because usually there's a reason for it. And they often have other fractures. As far as I know, this X-ray doesn't have any other abnormality there. Fine. Okay, so what do people think is going on here? Seems to be rather busy. Yes, precisely, Andrew. It might be a pericardial occlusion, that is true, or it might just be an enlarged heart. It's pretty hard to say on an X-ray, but the main thing I wanted people's attention drawn is this is a classic picture of heart failure. Now, with heart failure, or congestive heart failure, I should say, the signs to look for include a number of different things. You've got your blunting of your costophrenic angle here, so just probably there's some pleural effusion going along there. You've got the ratio being definitely more than 50%, just eyeballing it. You've got the upper lobe diversion, as people say. So basically, as your low lobes get congested, the upper lobes try to pick up the slack, and that functions. It's a homeostatic mechanism, but the thing you see on a chest X-ray is that the vasculature going to the upper lobes is more prominent because of that. Excuse me, I'm just going to have some water. So that's what you see here. You can see that the upper lobe vasculature is more prominent than you would expect it to be. And I have, in my very amateurish way, sort of drew out what classically is called backbone shadowing, but this is all interstitial fluid. This is a fluid that's leaked out into your lung, and the patients classically describe this with the sensation that they're drowning, because in a way they aren't wrong. They literally are. There's fluid leaking out into their air spaces because the heart just isn't able to pump, or we've given them too much fluid in this case. So yeah, this is your classic picture with heart failure. And it's again another favorite of the examiners. Now, I've just tried to highlight here this here. Now, this is something that everyone, I don't know about you, but my examiners love asking me about is curly B lines. Curly B lines are basically fluid accumulated in the septal spaces, which are not normally visualized, but because there's fluid accumulated there, you can visualize them. And they come in many different forms. There's curly A, B, C, D, which is actually something that the old textbooks had a lot of. These are what curly B lines look like. Curly B lines start at the periphery of the lung field and extend linearly. And they often form this kind of ladder or step-like appearance. It is actually quite subtle. So if you go back to the previous film, if you zoom in, you might actually be able to see, if I can draw here, you might be able to see, you know, going along there, that kind of, as you can see, they are very small, but if you do see it, it's pathognomonic pulmonary edema secondary to heart failure. So, and it makes you sound really smart. So, oh, I can see pathognomonic of this. If you can't, don't worry about it. It is a subtle sign. Just make note of all the other features that will probably give it away. And yeah. Okay, so moving on to the next case. Okay, now along the same lines, I've got another case here. I have 30 to 40 seconds. See what you think, and then I'll try to go through it with you. So in this case, it is another case with a patient with heart failure. Now, the things that are giving this away here is one, you've got your pacemaker here, suggesting that this gentleman is a single lead pacemaker with, I would say cardiomegaly, but it's hard to comment because it's just so much, but I would say it is quite likely that this is cardiomegaly there, definitely. You've got a lot of interstitial lines here. You've got some upper lobe diversion and probably most prominently seen on the left, but also present on the right. You've again got this battling appearance of interstitial pulmonary edema, most prominently in the lower zones rather than on the upper zones here. And now this is just something I wanted to go through, as I mentioned earlier. This is probably some detail, but if you can get this, it's absolutely sort of great. Curly lines basically come in different formats. You've got your curly B lines, which is what we noted here, and I hope you guys can make out. Here in blue, you've got your curly B lines because they extend from the periphery and go sort of linearly along there. You've got curly A lines, which are these septal lines that go towards the hilar region. And you've got your curly C lines, which sort of don't extend all the way there. Again, as long as you just say, I can see curly lines present, which indicate interstitial accumulation of interstitial fluid, secondary pulmonary edema, that should be absolutely fine. Right, moving on to the next case now. Yeah, so that should be fine. We're going to probably speed up a bit now. I'm just going to fly through these. So here you've got very clear abnormality here, which is your classical effusion. The giveaway sign here is that you've got a meniscus here with an effusion. This is sort of a whiteout of the area underneath here. And you've got relatively normal lung superior to that. Usually with pleural effusions, you can also have a bit of mediastinal shift, but it's so hard to see here because everything is whiter out on this side and this side. There might be a bit of shift there, but it's not that prominent. If you have a whiteout of the lung, you probably see it more prominently because the trachea will be deviated because it involves the upper zones rather than the lower zones. Fine. Now, in this case, there is two things that I want people to catch. I'll give you guys 15 or so seconds. And then we can do that. So yeah, so this is probably a case of surgical emphysema. So surgical emphysema is where you have exactly well spotted. In fact, quite a few of you guys actually got it well spotted. Yeah, so you've got air trapped in tissues. It's quite prominent whenever you see it. It looks quite scary, and the reason for that is you can see this chest drain there. Now I don't know if you can make out it's going across there. It's probably because the patient may have had an pneumothorax that they were trying to drain. And in the process of inserting the chest drain, it caused some air to leak into the surrounding tissue. And that sort of, the picture sort of fits. So that's just something I want you guys to notice. There's another drain going along there as well that I didn't highlight, but just for you guys to be aware of. Fine. So that's that chest drain. Just bear that in mind. They come in different forms, but you've got your usually associated with some surgical emphysema. In fact, I suspect there's probably a degree of surgical emphysema on the right-hand aspect here that I didn't notice earlier. So we can just move on. I'm having technical issues, but it's not that important. Fine. Okay. So what do people make of this very crowded looking film? We'll give it another 15, 20 seconds. Potentially. Yes, yeah. So there's bilateral, peripheral, widespread disseminate or widespread disseminate, the other words, ground glass shadowing. Now, I don't know if you guys, in the current context, what does that make you think of? Yes, exactly. So this is sort of your picture of moderate to severe COVID. This patient is intubated. You can see an endotracheal tube ending there. Bear in mind, endotracheal tubes are meant to end superior to the carina, usually by a few centimeters. If they go beyond that, that is bad because you end up blocking one lung and you can get lobar collapse and so on. But yeah, you can see the bottom edge of the endotracheal tube on here. Just bear with me. Let me just draw on here. So you can see the bottom end of the there. So that's the endotracheal tube going along there. And you can just about make out the carina along there. He's also got a central venous line there. Yes, excuse the terrible writing, I'm so sorry. Which is located into the, probably going a bit into the right atrium. Usually you'd want it a bit higher than that, but if this patient's in ITU, they're probably going quite badly. You've got multiple ECG leads going along everywhere, and you've got bilateral shadowing. So this patient, probably in ITU, probably not doing very well with COVID. I suspect they might throw this in the exam since we're still in the midst of the pandemic. And you've also got an NG tube just along there. You can't actually see the inferior aspect of the NG tube, just because the film sort of is probably not aimed at looking at NG tube placement, so it doesn't extend all the way till there. Yeah, so those are most of the prominent things I can see on here. So yeah, no, you might be, I don't know if you guys will be thrown, but even if you are thrown a film with multiple tubes and lines in there, just go through them systematically. Remember your basic anatomy. So this is roughly where the this is roughly where the right atrium is. So if anything terminates around there, it'll probably be a central venous line. Remember the carina, that's an important landmark because if you've got a tube going past it, that's most likely an NG tube that should go significantly below it. If you've got a tube terminating just above that, that could be tracheostomy, or it could be a endotracheal tube. Yes, so yeah, so that's some of the main points I wanted to just draw your attention to here. How are we doing for time, guys?
Thinking maybe another 5-10 minutes max, man.
Okay, that's fine. Yep, fine. I've labeled them there. Do you guys still want to? Because I think George is mentioning maybe a bit of a break between the two, or do you guys just want to go straight into abdominal X-rays?
I don't mind if we just carry on. I think people might,
Yeah,
but
that's
it's up to everyone really.
this general feeling going on. Fine. Okay, so I'm happy to carry on, and then if we have a bit more time, brilliant. If you have a bit more time, we can just do more cases. There's no shortage of cases to go through. Yeah, okay, fine. So similar to chest X-rays, I've sort of always used this sort of pattern, Abdo X, because I'm a simple person and I can remember the simple sort of patterns. So air within the context of an abdo film, if the air is outside of the bowel, that's usually very, very bad. It also makes it I'm sorry, and Andrew's just asking what time we would have to finish. I think it would take maybe, I will be done with abdo X-rays in the next 10 minutes or so, maybe 15 minutes at a stretch. And then Sanjeev's talk, I'm not sure how long.
So if you could maybe wrap this up in 5 minutes, because mine's going to be probably 40 minutes, and then we can try and finish on time at 7:30.
Okay, that's fine. Yeah,
Yep.
I can blitz through this. Most of them fairly self-explanatory. Fine. So roughly around 7:30, Andrew, is the sorry, I meant to say 8:30. 8:30, not 7:30. Yes, that will be going back in time. Right. So yes, going to the pattern, you've got your air outside the diaphragm, which is bad. Bile gas pattern, I'll go through this in detail. Densities and calcifications, I've not gone through in too much detail here, but we can talk about that if people want. Soft tissues and organs and external artifacts, which are obvious whenever you see them, so usually radio opaque. Right, let's go through the cases. Right, this is a normal film. I just wanted to highlight certain bits and bobs here. This is where you roughly see the large bowel along there. You can also see some loops of small bowel along there. This is the classic pattern. Got your cecum on the right-hand side, and you've got your rectum, sigmoid with ascending colon and the splenic flexure. You can often see the hepatic flexure as well there. And usually bowel gas seen in the usually bowel gas seen centrally tends to be small bowel, not always, but sort of roughly that's the outline of where you'd expect things to be, which we'll see more in cases. Soft tissues and organs, there's the sort of things you can see, often not very prominently unless there's something wrong going on, but you can deliver stuff in the spleen superiorly. You've got your transverse colon with the splenic fracture and hepatic fracture being particularly important to note, and your kidneys. You've got your bladder inferiorly, which I haven't really highlighted, but that's not something you guys need to worry about too much. You've got your psoas muscle, so if there's a psoas abscess or something like that, you might see it. I think Sanjeev's going to talk about fractures, but if there are typically severe fractures, you can see it in an abdo X-ray as well, something to bear in mind. That's just a rough overview of the basic anatomy. Awards. I mean, these slides are available, so if people want to go back and look at this in more detail, they can do that. Let's get on to the meat of the matter. Now, the most important thing is looking for air and differentiating where it's located. So you've got your gastric bubble, which is on the superior left aspect of the body. So it'll be the right of the film, that looking from the way you look. You've got valvular combinantes, which are basically dense bands of muscles that go all the way along the intestine. And then you've got your haustra, which are incomplete bands that don't go all the way across. That's usually how you distinguish small bowel, large bowel. So these are all basics that you guys would know. This is probably one of the most important things you will learn here, is that usually you're only meant to see one side of the bowel. If you can see two sides of the bowel on both, if you can see bowel on both sides, that's known as double one side. And that means that there is free gas surrounding the bowel, because you've got gas on the inside, gas on the outside. That means you see both sides highlighted. That is the single most important thing you can probably take away from this, because that indicates there's either been a perforation or potentially this person had recent surgery, but if you're not given the context for it, always mention, I'm worried about a perforation. I mean a peritoneum. And let us talk about, yes, and the other thing is a 369 rule. It's all on the screen. Basically, 3 centimeters roughly what you expect small bowel to be, 6 centimeters for most to large bowel, cecum being one exception where it's allowed to be up to 9 centimeters. Right, looking through simple cases, I'm just going to blitz through these. This kind of mottled appearance extending all the way from the rectum is your classic appearance for fecal loading. Fine, this would be small bowel, as you can differentiate it. It's dilated and it's called valvular prominently. It's going all the way through. Again, this is another example of small bowel. This is a large bowel. It's much larger. You've got incomplete band going all the way through, so that gives a very large bowel. This is another case of large bowel obstruction, specific case of toxic colon. What gives it away is you've got lead piping on the left-hand side, which is where you've got complete loss of haustral folds and enlargement. This is a medical emergency. As mentioned, most awards mentioned, this is what's known as the football sign. So you've got air accumulating to the top of the abdominal cavity with small bowel obstruction, and also you can see clearly the double wall sign as well. These are probably things you'd have to go back to and look at, but it's all on the slides, and I've highlighted that as well. If you can use your imagination, it looks a bit like a football. That's why it's called what it is. This is your classic coffee bean sign, which would be to do with sigmoid volvulus. And it would be pointing, if it's pointing, base appears to be pointing from the pelvis. Anything other than the right side of the abdomen, it would be most likely sigmoid, which is by far the most common. And yeah, no, I think that is probably where I'm going to give it a stop, because we've covered a lot in a very short period of time. Sorry, the last bit was a bit rushed, but everything is basically on the slides, and you will be getting the slides. And I've tried my best to annotate them as much as I can. So yeah, I think I will stop there. That's okay with you guys?
Yeah, that's great. Thanks very much for that. We can now just push on with Sanjeev's presentation.
Yeah, how's everyone feeling? Would you guys like just a 2-minute break, like a little comfort break, and then come back?
Yeah, that sounds fine to me.
Yeah, so how about a couple of minutes and then we'll get started, okay?
All right.
This last bit is quite short, so it won't be as long, all right?
All right. Okay, we'll give it in 2 minutes then.
Great.
Thank you, guys.
See you, Vamsi.
Thanks very much, Vamsi. That was really good. We'll post the feedback at the end.
Thank you.
George, would you mind doing me a favor? If you're there.
I don't think George is here. He's got a mock exam. What is it?
No problem. No, just wondering if anyone from the committee is here, if someone wouldn't mind being my eyes and ears on the chat box, because it'll just make it a bit quicker, I think, if someone just shouts out any questions anyone has, or if anyone wants to volunteer. It saves me from flicking back onto the chat box and get through the slides a bit quicker.
Yeah, that's fine. Me and Aaron can watch the chat, and
Thanks, guys.
We'll shout anything out to you.
Brilliant. Thank you very much. Great, we'll get started in another minute, okay? Okay, guys, we'll get started if that's okay. Whoever's still on a break, don't worry, just come and join us whenever you're back. So I'm going to be talking about musculoskeletal plain films. It's quite an underrepresented topic in medical school, I feel, at least when that was my experience when I was doing it. There's obviously a lot of teaching on chest radiographs, but less so on abdo and even less, I feel, on musculoskeletal side of things. So it's quite a broad topic. There's lots of different parts of the body that you can image. So the point of this talk isn't really to go through every single part of the body and how different types of fractures may look like, etc. It's more to give you guys sort of a structure so that if you do come across it on your OSCE, it's not something completely alien to you. And it's not going to be something like a chest X-ray, I don't think, where an entire station is just going to be based on this. It probably is going to be an add-on to maybe like a musculoskeletal examination or an add-on to something else. But if you just have the structure that we're going to go through here, I think it'll make a big difference and when you're presenting it, okay? So, sorry, excuse me. Working, fantastic. So the outline we're going to do for this talk is, first of all, goes to the systematic approach I just mentioned. We're going to go a little bit about describing fractures, because I think that's what the key is going to be here. So the two main pathologies, realistically, are going to come across in your third year OSCE, or even in your finals, actually, is either a fracture or a dislocation. And I've got around 7 cases, which I'm hoping we can just whiz through, and hopefully I want as much participation as you guys can get. And yeah, we'll hopefully finish on time at 8:30. Great, so here's the approach that I tend to use. People have different approaches, but whatever you've been taught, as long as it kind of covers roughly what's covered on this slide, I think it's absolutely fine, whichever approach you want to take. So just remember, in your OSCEs, it's all a tick box process. So the diagnosis is going to only be one small percentage, and you can pass without getting the diagnosis. So that's why it's really important not to neglect the simple stuff like demographic details and checking adequacy. Because at the end of the day, if you see an X-ray and you don't know what the abnormality is, don't panic, go through your systems, seem like you've presented before, seem confident, even if inside you don't feel like it. And then at the end you say, okay, I haven't found an abnormality, but look, I have got a system and I know how to look at a plain film. And that's what the most important thing the examiner says. Okay, so specifically for, sorry, let me just rid of this, specifically for musculoskeletal plain films. So the first thing you do, as Vamsi had also said, same thing for chest X-ray, same thing for any X-ray that you look at, make sure you present the demographic details. So you have to say, this is a blah radiograph or blah X-ray of Mr. X, Y, and Z, 76-year-old male. And combine that with, is it adequate or is it inadequate? Now, there's lots of rules for chest X-ray. With musculoskeletal plain films, it's a little bit more tricky. And I don't think they're going to penalize you as much, and I don't think they're going to give you an inadequate X-ray. But I think simple things like make sure the entire bit that you want to look at is there, so you're not having half your humerus cropped off, for example, if that's what you're looking at. But I wouldn't stress too much about that. I would just kind of keep it simple and say, if it looks all right, technically adequate. As opposed to chest radiograph, I think you do have to have a bit more of a systematic approach, which Vamsi went through. And with MSK films, describing the radiograph is really important. So all chest X-rays are either PA or AP, it's very simple. Whereas in MSK, you do have to have sort of some idea of where you're looking at the body part. So for example, you may say this is a lateral view of the tibia or an AP view of the humerus. And it's really important to have that little phrase to show that you know how to look at the MSK plane. Okay, and then just like chest radiographs, you see fracture jumping out at you, go straight for that and start describing it. And then we'll go through that in the next slide. But if for whatever reason you don't see an X-ray and you're thinking, oh God, what do I do? Don't worry, just stop and say, okay, I can't see anything immediately abnormal. I'm now going to adopt my systematic approach. And that's the phrase that I use. And from what I've heard from you guys presenting, you've had equally valid phrases. It just slows you down and shows the examiner that you aren't going to be fazed by something which you haven't seen before. You are not quite clear what the answer is. So the first thing you do in your systematic approach is you make sure whatever bone is presented to you, carefully in your mind, or even with a pencil, go and trace the cortical outline. What you want to make sure is that there's no steps in the cortex or any obvious breaks or any subtle breaks as you're going through all the way around the bone, okay? And then hopefully then once you spotted the fracture, you describe it. And that's the bit I'll go through separately. If there's, regardless if there's a fracture or not, the next thing you do is then you assess the joints, mainly I think in the OSCE for dislocation. You do look at other things, for example, things like joint space narrowing, but I think it'll be very mean for them to start giving you things like rheumatoid arthritis in your OSCE. So I wouldn't worry too much about that. And then similar to the chest X-ray, you look at the soft tissue. So remember in the chest X-ray, last there's bones and soft tissue. Bones you've obviously already been looking at. So remember the soft tissue bit of the bones and soft tissue. And then wrapping up. So what do I mean by wrapping up? So that's sort of a slick way for you to kind of have a conclusion at the end and kind of move it on from the presentation. Because one of the things that really makes you stand out as a candidate in the OSCE is presenting it, but then if you stop afterwards, the examiner will then have to prompt you, which is absolutely fine, but a really good way of sort of really standing out and making sure you get those tick boxes in really quickly is just to kind of continue and just say, right, in conclusion, there's this, and then a management plan. So what I tended to do was have a sort of a one-sentence conclusion. So you'll have a description of the fracture itself, but then you say, in conclusion, there is a distal radial fracture. And you'll kind of go into almost kind of robotic mode. So they will probably show you, hopefully, 2 views. But if they have shown you just one view, ask for the orthogonal view. And what I mean by orthogonal is, if they've given you an AP, ask for a lateral. If they've given you a lateral, ask for an AP, okay? Sometimes it's appropriate to ask to joint above and joint below, and we've got one case where that's appropriate. And then go through your management plan. So with fracture management, I have this mantra taught to us by the orthopedic surgeons when I was in uni. So optimize, reduce, hold, rehabilitate. I'm not sure if you guys have come across that, but it's a really simple way of just saying, this is how I'll manage a fracture. So optimize means things like resuscitate the patient if they're unstable, they've got open fractures, etc., etc. Reduce means getting the fracture back into its normal alignment. Hold, so things like plaster of Paris or operative procedures like nails and plates and screws and that kind of stuff. And then rehabilitate, which is sort of an MDT input where you get the patient back on their feet and or whatever part of the bone they've fractured, get them their function back, essentially. The other thing that I didn't write on here, so it's really important for both your written exams and for your OSCEs, is to remember, if there is a fracture, make sure you always mention that you'll assess neurovascular state. Very important, okay? So I'm sure you guys have mnemonic fatigue by now. I've got another mnemonic, I'm afraid, but memorizing the mnemonic isn't as important if you are confident, once you've got this in your head, that you have a pattern that you go ahead with, okay? So the mnemonic I learned was PAIDS, so pattern, anatomy, intra/extra-articular, deformity, or soft tissue. And so what do I mean by that? So if you see a fracture, describe the pattern. What does it look like? And I've put in some phrases in there that you might find useful when describing. So first thing I say, is it complete or incomplete? Is it going all the way through the bone or just partway through? Comminuted, does anyone know what comminuted is? Yes, MAS, yeah, absolutely. 4 Rs, research, reduce, restrict, rehab. That's even better. That's even better, yeah. Good, absolutely. So lots of bits, multi-part, that's absolutely right. So if you see multiple fragments, then you use the word comminuted. And then with simple fractures, there are different orientations that you may look into. Apologies for my spelling mistake there, but it's meant to say transverse. There's transverse, oblique, spiral, and complex. And I'll show you some pictures just before we go through the cases of what they look like. Anatomy. So very simply, which part of the bone? Let's first say which bone, first of all. Is it the tibia that's fractured? Is it the humerus? Is it the superior pubic ramus? And say which part, especially with long bones. This is where having the idea of thirds comes in handy. So is it the proximal third? Is it the middle third? Is it the distal third? And just a simple description like that will make it seem very accurate that you know where you've seen the fracture. The third thing is whether it's intra or extra articular. And what I mean by that is, does the fracture in extent involve the articular surface or the adjacent joint? Because that does change management. And the fourth one is very important, so deformity. And there's lots of different kind of components that come into this. And I'll go through some of the pictures to describe them as well. And finally, S, the soft tissue. So that's gone in again with the pattern, the checklist I had before as well. Sorry, just bear with me, guys. Yeah, lovely. So yeah, and finish off by describing the soft tissue. So commonly the soft tissue abnormalities you'll see are things like soft tissue swelling. Very simple thing, but even if saying it will show that you've got a very systematic approach to describing your fractures. You don't always see it, but it's useful if you have seen it. And joint effusions, which is a really important thing to keep in mind, particularly in the knee and the elbow. If you guys can know what a knee and elbow joint effusion looks like, it's very handy. So in terms of describing fractures, I'm just going to quickly go through some of them. So this is what a transverse fracture looks like, clean just across a horizontally orientated fracture. This one's a linear fracture. There's the sort of perpendicular to the transverse fracture. There's oblique, ignore this one. And then there's spiral, so there's kind of like a staircase going up there. Very useful if you do see it, usually happens in long bones. And this is what a comminuted one, so just like I described before, multiple fragments. And then these are the deformities. So it's useful to have some of these phrases as well. So the most common one is displacement. So that's when you have the bone completely moving. Angulation, where sort of you have one bit acting as a pivot and the rest of the bone kind of angulates, if you can kind of get that in your head. Shortening, where basically, as you can see, there's overlap of bone and you have the overall length of the bone shortening. And the most difficult one, I think, to describe, and I wouldn't worry too much about this one, but rotation, where basically the orientation of the cortex remains roughly in alignment, but the actual shaft rotates on that axis, if that kind of makes sense. But the whole point of kind of going through all of this is they don't want a beautiful 1,000-word description. They just want you to make sure that you go through each of these steps, make sure you've assessed deformity, you've assessed a pattern of fracture, that you've assessed location of bone, and having some kind of attempt of describing it. Okay? Is that all right, guys? Any other questions at this stage? Because I think we're about to go on to the cases. Yes, we are. Just give a minute if anyone wants to type anything in the chat. Good. Okay. I don't think there's any questions. Is there, Vamsi?
No, there's no questions at all sent.
Brilliant. Thank you, guys. Great. Okay. So can I get someone to volunteer for this first X-ray, please? I know it's daunting, guys, doing it in front of your classmates and all that. But if you guys can do a all right presentation here, even if it's completely wrong, if you get over that fear here, the OSCE will be a breeze, honestly. You guys have given up your 2 hours of the evening to do this. So I think it'll be really helpful if at least some of it you guys present, if that's all right. Do you have any takers?
I'll go for it.
Brilliant. Who is that?
Yes, it's Ellie.
Ellie, fantastic.
Hello.
Are you happy to get cracking?
Yeah, so
Brilliant.
I'm currently looking at, I'm assuming it's the right arm of this patient, and there's adequate exposure, and I've got an AP and a lateral view. On looking at the bones, so looking at the carpal bones, they look all intact. And what I can see of the metacarpals, they look intact too. Then looking at the radius and the ulna, so the ulna looks intact and I can't see any visible deformity, but looking at the radius, there is a deformity at the the distal third of the radius, and it looks like it's extra articular. It looks comminuted, and I think there's roller displacement. I believe this might be a Cole's fracture, and there's visible swelling of the soft tissue surrounding the joint.
Good. So in conclusion?
In conclusion, I believe that this is a Cole's fracture. It needs manipulation under anaesthesia and putting in a below elbow back slab, and then re-x-raying to make sure that it's in the correct position, followed by physiotherapy. And if it fails to unite, we need to do possible ORIF.
Perfect. Very, very good answer. And I think that would have definitely got you a pass on the OSCE. So well done, Ellie. So this is absolutely right. This is a Colles fracture. And I think what really stood out, Ellie, was the fact that it was clear that you used a systematic approach. So just out of interest, Ellie, did you spot the fracture immediately or?
Yeah, I did. And then I tried to do it in a backwards way. That's
absolutely fine. So I really liked how you did it. If you do spot the fracture straight away, and if you're confident, just go for it. Say there is and then start describing the fracture. If you find in the OSCE like you're not sure about the fracture, you want to have a bit of time to think about it, your approach was absolutely fine as well, just to buy yourself some thinking time, because the way you did it, it came across completely fine. So I'm happy with either approach. So the only thing I would change is, so maybe describe the pattern of the fracture first of all. So say it's a transverse fracture. So I don't know if I can convince you the fracture is orientated this way. Yeah. And just be careful about your dorsal versus volar. So dorsum of the hand is this bit, which is, if you can imagine my hand looking up like that and comparing yourself. I just realized I don't actually have my camera on, do I? I do apologize. But anyway.
Yeah, you do. You do.
I do. Fantastic. Yeah, that's fine. That's fine. So this is the dorsum of the hand, and this is the palm of the hand, or the volar aspect. So actually, there's dorsal angulation and dorsal displacement. Does that make sense, everyone? Let me know in the chat if that does. Okay, so but the rest of your presentation was fantastic, brilliant. Can I get a second taker for this one? You guys can have a look and then decide.
I'm happy to do it if no one else is.
Perfect. Is that Alex?
Yeah.
Brilliant. Yes, please go ahead.
Okay, so this is a lateral view of the lower leg. You can see the ankle joint and the foot and the sort of tibia and fibula visualized in this, and the penetration is good. Moving down through the bone, I think I can see a tibial fracture in the midshaft region, and the fracture looks slightly oblique, so I want to say it's maybe a spiral fracture. Moving further down to the ankle joint, I can't say for certain, but I think the ankle joint looks like it's intact, and that's it. So in terms of summing up, I'd say this is a midshaft tibial fracture, and you'd want to reduce it and hold it with a below knee back slab.
Good, fantastic. And is there anything else you'd want to do radiologically?
I would want a alternative view, so the AP view of the.
Absolutely, yeah. So make sure you remember to say that, because I think if this does come up in the OSCE, I think it is very potentially another tick mark. But very, very good presentation, Alex. Yep, you absolutely were right. You spotted the fracture. So I think in terms of other things you could have mentioned, so remember to describe the deformity. So say, in this case, probably the reason why you didn't mention it is because there isn't much deformity. But just remember to just mention it, even if it's just 2 or 3
Okay, so like the soft tissue.
Oh yeah, well, so we'll go through soft tissue as well. But what I meant is in terms of the deformity of the bone of the fracture. So the way I would describe this is there is a distal tibial fracture which is minimally displaced. Yeah, so that phrase minimally displaced is quite handy because you kind of just puts in all that things together and just say, tells yourself or tells the examiner, right, actually, I've assessed the deformity, there isn't much, okay? The other thing I would say, so yeah, soft tissue, it's not such a big deal here, I would say, but you could say there's no significant soft tissue swelling, I would say, because if you notice here, the skin's like not too swollen here. And I think you were absolutely right in saying the ankle joint is well maintained. So that's why you want another view. You want to image the ankle as an AP, because that's where usually the instability of any ankle dislocations is better seen. But yeah, it's good that you mentioned that. And the other thing I'd mention is whether it's intra or extra-articular. But to be honest, because you mentioned this mid-tibial, it's assumed that it's not. But it's a good thing just with your osteopicus, if it's on there, say it's extra. It's just such an easy win. And it's those kind of little things that if they put it in the exam, you're not exactly sure what they have in the tick quiz. It's safer to just mention everything than to end it off. Does that make sense, guys? Good, well, fantastic. So I'm very impressed with the standard of presentation so far. So we're going to make it a little bit trickier now. I say that means that no one's going to volunteer, isn't it?
Sorry, so we just have a couple questions.
Oh, sure. Okay, yeah.
So,
do you mind shouting them out for me?
Yeah. Needy asks, what type of fracture is it? A complete oblique or spiral?
Oh, so yeah. So apologies. So Alex was absolutely right. This is a spiral. So this is why asking for an AP is really helpful because it'll confirm it. But if you can kind of follow my arrow, it's got that stairway type morphology. You can convince yourself. So an oblique would kind of just look just like that. But the fact that it's going like that and then now it's going up is more in keeping with the spiral. Does that make sense?
Yes, thank you.
Great, thank you. And what was the second question?
The second question was, would you need other views to be sure on the displacement, etc.?
Yes, you would. You would, absolutely. Which is why in your OSCE, if they're giving you one view, you can only comment on that one view. But that's why it's really important when you're concluding in the end and say, okay, this is the fracture that I've seen, but I would like an AP view to assess further. Yeah. But you can only describe what you're seeing. So you won't get penalized if there is massive lateral displacement on the AP, which you're not seeing here. But based on this lateral, you can only say that it's minimally displaced. Yep. Good. Shall we move on if there's no more questions? Can I get a volunteer for this one as well? I'm just going to keep it on time. Anyone, please?
I'll have a go if you want.
Lovely. Who's that?
It's Sarah.
Sarah, fantastic. Please crack on.
Okay, so I'm looking at an AP view of the right ankle in an unknown patient taken at an unknown time. I can see the exposure's not great, but I guess it's adequate. And the most obvious deformity I can see is a fibular fracture at the syndesmosis or thereabouts. The tibia looks intact, and I can't see any talar shift, I don't think, but there might be a little bit. So this patient would probably need the fracture reduced and put in a Bologna back slab if it's at the syndesmosis, and then review in about 4 weeks, and then physio and all the rest of it.
Good. Fantastic.
That's all I got.
Lovely. No, that's perfect. Perfect. Well done, Sarah. That was a really nice presentation. So you're absolutely right. It's a distal fibular fracture. So I don't know if you mentioned, Sarah, did you mention Weber? I don't know if I missed that.
No, I just said it's at the syndesmosis. It would be a B, right?
Yes, that's right. So this is where a Weber classification may come in handy. But to be honest, even in the OSCE, if you don't remember it, you're not going to get penalized. But it might just help you sort of sum up the radiograph a bit more succinctly, but it's really not going to come up in the mark scheme or anything like that. But yeah, absolutely. So the way I describe this is there is a distal fibular fracture, which extends to the level of the syndesmosis. It is minimally displaced, extra-articular. And I know you mentioned the thing about the Taylor shift, but I would say there's no evidence of dislocation. So the rule is this medial clear space here, the bit where I have my arrow at the moment, should be less than 4 millimeters. So just imprint this in your head. This is what is normal is. In the OSCE, they're not going to be cruel and give you something subtle. If there's Taylor shift, it will be like really, really obvious Taylor shift. Okay, so I think that's the general rule with your third year OSCE. Do not worry about the picking up the subtle pathologies. I think what I've given you here is probably as subtle as it's going to get. Okay, good, well done. And the other thing, Sarah, that I really liked, and just forgot to pick it up for the previous cases. It's a really small point, but I know it's artificial that I haven't put the name or anything, but in the exam, even if they don't put the name, make sure at the beginning you say, this is a blah, 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 radiograph of an unknown patient taken at an unknown time or something to that. So just to make sure that they have ticked off that you've checked demographic details or lack thereof. Yeah, because that will be a really, really easy tick points, and make sure you include that with any X-ray. Okay.
So we just have another question.
Yeah, go for it.
It's just Maz is asking, how do we work out the Mortise from an AP view in something like this?
What do you mean by that, Maz? Do you want to just unmute yourself if you don't mind, if you're able to?
Just ignore the background music, but it looks, I don't know, for me it looks quite similar. Is there like some sort of way to work out whether this is, because I know they do the angle of the foot in, it's like dorsiflexion and all of that. How do we work out which is which?
Oh, I see. Are you asking how do you work out whether it's a Mortise view or not?
Yeah, how to work out if it's AP or Mortise view.
Oh, fine. Okay. I really wouldn't stress about that. They will, if they're going to give you a one in the OSCE, it's going to be either a medial malleolar fracture or a lateral malleolar fracture, and it will be overwhelmingly a AP view. The Mortise view is basically where you'll see this Taylor dome nicely in profile. But definitely at this stage, don't stress yourself up about differentiating between the two, because I'll just keep it simple and just say AP, because even Mortise view is technically an AP. Is that all right?
Brilliant, thank you.
No worries. All right, guys, so who wants to do the next one? I'll put it up first so you guys can have a look first. It's a bit more complex, so this is where I want whoever is presenting this to really slow down and use that checklist that I used before or mentioned before, because I think it will come in handy for this quite complex X-ray, okay? And please don't worry about getting this wrong, because I think this is probably one of the hardest ones on here in terms of description. If you can do this one, you're doing really well.
You want me to have a go?
Yes, is that Maz again?
Yes. Yeah.
Lovely, yes please, Maz, if you don't mind.
Okay, so it looks like we've got a lateral X-ray of the forearm of an unknown patient and unknown arm. In terms of the adequacy, seems fine, can see everything, can see both a little bit of the distal radial ulnar joint and the elbow joint. The most prominent things I can see on there is a fracture of the proximal just trying to work out which is which.
Don't worry, yeah, it's tricky.
The proximal ulnar.
Yeah, that's right.
It seems to be a completely displaced with dorsal angulation of the proximal half, and the distal half doesn't seem to be angulated as much in either which way. There also seems to be a dislocation of the radial head in the dorsal, no. It's dislocated and it's okay. So other than that, there seems to be tissue swelling and nothing else to note. The bone itself within the cortex and the medulla looks it looks to be good quality bone. Doesn't seem like there's any underlying pathology there. I would say that this is distal radial head fracture, and it's either Montiega fracture. And this patient would need ORIF and splinting and the rest of it, and cast.
Fantastic. Do you have anything else to add?
I'd also like to see a AP view, and I'd also like to see an AP view of the forearm and the elbow joint, and if I could and be cheeky, I'd want to see the shoulder joint as well, because it looks like it's high trauma. So.
Okay, yeah, fine, very good. Fantastic presentation. I'm very impressed with that. So I have very little to add to that, Maz. So I think one of the main things that was difficult was working out whether it's the radius or ulnar, would you say, Maz?
Yeah, I had to double check.
Yeah, no, don't worry. So I also used to struggle with this. So the way you need to remember it is look at the width of the bone near the elbow and look at the width of the bone near the wrist. So if it's bigger at the elbow, it's the ulnar. If it's bigger at the wrist, it's the radius. So can you guys see that? So look how wide this bone is here near the elbow. Look how small this one is. So this big one is the ulnar and this small one is the radius. And then it goes the other way around when the closer you get to the wrist. So the ulnar gets smaller and the radius gets bigger. Does that make sense? Good, okay. So you're absolutely right. So there's lots of elements to this. So I think you hit pretty much all of it. And you've got the demographic details, which is really important. You mentioned that's a lateral one. And one subtle thing which you said, which was really important, is that you said unknown arm, I think, which is really important because when it comes to describing these fractures, you can say everything like humerus, etc., but it's really important to mention the laterality as well. So if it's mentioned, like for example on this one, there's a nice R on here, that's your clue to say right. So say simple thing is saying this is a AP radiograph of the right ankle is really important. So well done on that. So this is a transverse fracture, I would say, of the proximal ulnar with significant displacement associated with radial head dislocation, which is exactly what you said. So this is where it's really important, the beginning of that checklist. It is important to know you're describing fractures, but remember, there is also other pathologies that can happen. So that's why I said things like, let's make sure once you've described the fracture, make sure you always assess the joints and always assess the soft tissue. So that's the thing that when you're going through your revision, and maybe if you are using these slides or whichever resource you're using, make sure that's imprinted in your head. Okay, great. I'll go through this one myself because it's a little bit difficult. I'm running slightly short on time. So this is a lateral view of the humerus, and the most obvious abnormality is a transverse fracture of the mid-humeral shaft with some anterior displacement of the distal fragment. There is a little bit of surrounding soft tissue swelling, but the most important thing is to look at the background of what the bone looks like. So if you compare how this bone looks like, which is nice and normal, and compare here, so this is what we kind of describe as a permeative appearance. So the background bone is abnormal and has a permeative appearance, and this raises a suspicion of a pathological. A pathological fracture is where you have a fracture where it's breaking because the underlying bone is diseased rather than because the trauma itself. Okay. So it would be really mean for them to give this to you in OSCE, I think, but just so you guys are aware, for sort of when you guys start working as F1s, which won't be very long from now, just that this entity exists, okay? Great. So I'm gonna...
We just had one quick question on the elbow.
No problem, yeah.
On the elbow fracture.
On the elbow, yeah.
The Gillespie one.
Yes.
It's just asking if the olecranon is fragmented too there.
Oh, yeah, so this is a really important point. So do you see, so that olecranon, yeah, there is a line going through there, but you see there's also lines going through here in the distal humerus, here through the radius, here through the distal radius as well. So can anyone explain what those lines may represent?
Child.
Yeah, exactly, it's a pediatric X-ray. So don't get thrown off, which is why I included this image, is don't get thrown off by pediatric plain films. They shouldn't give you a pediatric one, but just in case they do, remember if there's multiple lines going through ends of the bone, think this is a child, ignore that. They will give you an obvious fracture to focus on, okay? Good, have you got any other questions? Good. Okay, so these ones, I don't want anyone to present. Can people type in the chat box what they think this is? And Alex or whoever, if you don't mind saying what people are saying in general. Actually, I can get it up here. Good, fantastic. Fantastic, yeah, absolutely. This is a shoulder dislocation, more specifically anterior dislocation, which is the more common of the two. So it would be mean for them to give you a posterior dislocation because they are harder to spot, but as long as you've imprinted this image. So this is the glenoid joint, or where the glenohumeral joint should be. What you should have is the humerus nicely up against this little glenoid here, but it's all the way down here. Fantastic. And the other one I wanted to put in was, sorry, laptop's very slow. Bear with me, guys. We'll be done very soon. So I think I only have 2 more cases after this and then we'll be finished, okay? As soon as my laptop starts working. Yeah, lovely. So, so there's no fracture here, or obvious fracture anyway, but can someone tell me what the abnormality on this one is? Another one that's worthwhile. So specifically, it goes back to what I was saying about looking for soft tissue. So there was 2 things I mentioned. One was looking at soft tissue swelling. There was another entity, which is what this is. Any answers yet?
So we have a fat pad sign or a sale sign from Ellie.
Okay, so sale sign is interesting. It is roughly the same entity, but a sale sign only happens in the elbow. So you don't call it the sale sign here, which is the knee, but it represents the same thing. Get the chat box up here.
So we've had patella dislocation as well as a suggestion.
Yeah, okay, so patella dislocation is usually on the A piece because on the lateral, it can move side to side and you won't be able to tell as clearly. Ulcer is probably getting there as well, like how Ellie did. You guys are getting there. So there is kind of a something to do with fat and blood. So this is lipohematorosis, okay? So what you're seeing here is, do you see kind of this layer of fluid density kind of right up here, where this is where you get joint effusions in the knee. So what you do is you look at the patella, and you look above the patella, and that's where joint effusions tend to accumulate in the knee. So this is what we call a suprapatellar effusion. If it was just this fluid density, now what you're seeing on top is this layer, and then this little bit of fat density above that. So that makes it a lipohematorosis. There's fat density and there's fluid density, and that's specific for lipohematorosis. And that's usually an indicator of some minimally displaced fracture, which you may not pick up on an X-ray. And usually these patients go on to have a CT. Okay, good. Okay, I'm going to wrap up a bit quicker now, if that's all right. Keep typing any questions you have, and I'll go through them as we go through. Okay, so hip X-rays. Oh, sorry, switching. So hip X-rays is very sort of a unique thing, and I think probably the most likely thing they're going to ask you in the OSCE if it does come up. And the main thing is actually, along with your usual system of tracing outlines, is being aware of this idea called Shenton's line. So tracing this medial cortex of the proximal femur and making sure that it's in continuity where my mouse is with the superior pubic ramus like this. Now here, what we can see sometimes is there might be a discontinuity. That discontinuity may make you kind of suspicious for a hip fracture. The other concept is, I'm sure you've seen this diagram when you're revising for your writtens and stuff, is this concept of intra versus extra. And the main thing that you need to be aware of in terms of the pathology of this is the blood flow in the proximal femur goes from the distal aspect, or lower down, to the proximal aspect. So if you knock off the intracapsular bit when you fracture the femur, you are more likely to lose the blood supply to this femoral head, and that's why it changes management. Whereas more distally, you kind of have other blood vessels that can keep the blood supply in. Okay, so I have 2 cases here. Would anyone like to present this one? Just 2 more, guys, I promise. We'll be done. You've been very patient. I want to get as many people involved as possible so you guys can sort of go away thinking you've got something out of this session as well.
Sure, I'll give it a go.
Brilliant. Is that Aaron?
Yeah, everyone's fine. I'll give it a go.
Sure.
All right. So sorry. Yeah. So this is AP X-ray of the pelvis of an unknown patient. And then looking at the, I assume it's an adequate X-ray. So the main concern that I see right now is of a left intracapsular neck of femur fracture. It's, would you say it's transverse or?
Yeah.
Sure. It's not displaced. I'm not seeing any of the deformities anywhere else. But I'm not, yeah, that's it. I'm not sure what else is there.
Yep, that's fine. So remember, go through your that mnemonic page. So have you described the pattern? You said transverse, absolutely. Anatomy, so you said intracapsular femoral neck, and you said left as well, which is really good because there are 2 femurs, so it's really important to say that. Intra-extra-articular, probably not as relevant here, I agree. Deformity, that's the main one.
Okay. So is that like whether it's displaced or not?
Exactly, yes.
So it doesn't seem to be, well, the fracture itself doesn't seem to be displaced, I don't think.
Yeah, so there's probably minimal displacement. So that's the phrase I would use because it's not completely enjoined. So you see how, so a completely undisplaced fracture, you'll have a line going through here, but you see this nice shape being maintained, yeah? Here you've lost that shape. So there is a bit of movement, there is a bit of displacement going on. So you'll say minimally displaced, okay?
That makes sense, thanks.
Okay, fantastic. And in terms of management, radiologically, what would you like to do?
So depending on the patient, I would either do a total hip replacement or a hemiarthroplasty. So depending if they're independent or not independent at all in their everyday lives.
Lovely, yes. That's right. That's how you'd manage the hip fracture. And before that, radiologically, would you do anything else?
Oh, I would like to have a lateral X-ray as well.
Fantastic. Very good. Very good. So yeah, that's right. So most intracapsular fractures, as you correctly said, depending on their life expectancy and their fitness, can be considered either for a THR or a hemiarthroplasty. So that's fantastic. So I think that's, I don't think you've missed anything else out there. So that's very good. Thank you, Aaron. And this last case, what I'll do is if people can shout out what they think is going on for this one. Or type in the chat box, whatever you guys would prefer.
Is it a right extracapsular neck of femur fracture?
Yes, very good. So yes, it is a right extracapsular neck of femur fracture, and Azhar has absolutely said trochanteric fracture. Very good. So this is an intertrochanteric fracture. So the trochanters, so this is the lesser trochanter and this is the greater trochanter. And if there's a fracture going through like here, which is exactly what's happening on the right, you call it an intertrochanteric fracture, which is an extracapsular. You kind of, if you can put both those phrases in, that's really, really good. And it shows the examiner, you know exactly how to describe hip fractures. And the reason why I put these 2 cases is these are the 2 that you're realistically going to get. So you're going to get an intracapsular, like the previous case, which Aaron presented, or an extracapsular intertrochanteric fracture. What this is. The only other thing I'd describe for this one is I would also say this is minimally displaced or slightly displaced. And you see that there's multiple parts to this. So there's the proximal femur, the distal femur, and then this bit, which is the lesser trochanter. So you can say a multi-part fracture, intertrochanteric fracture with some displacement or shortening, probably the phrase I'd use in this one. So that's my last case, guys. So basically take-home messages is with these plain film ones, with these MSK plain films rather, do not panic, keep it really simple, have the systems that I went through at the beginning at your disposal. Don't forget to include really simple stuff. I know it's going to sound really annoying doing it again and again, but that's literally what the OSCE is there for. It's a tick box. You just have to make sure you, like a driving test, go through everything in your tick box like a robot. And at the end, once you've covered everything, even if you get the answer completely wrong, as long as you've gone through the system, you should be getting up to that point where you're passing. And the rest of it is sort of just going through the common fractures that you might encounter, and maybe practicing with your friends or family even. Just get them to put up a thing for you, and you just practice in front of a mirror or to them, and just get into the habit of sort of going through that system, so that you're not having to sort of look into a book or look at a checklist. It should all be going through very smoothly in your head by the end. Okay, on my firewall. Great, so that's my last case. Do we have any more questions that's come out of this?
Yeah, no, that was great. Thank you.
Okay, sorry, it's overrun a little bit, guys, but I hope it was worth your time.
That's okay. So we've just put the feedback form in the chat. So if you guys could fill it in, because it'd be really helpful for the
Yes, definitely, guys. So me and Vamsi would be very, very grateful if you could fill it in, even if it's